Hello, everyone. My name is Mira Sofer, and I'm delighted to welcome you to today's webinar. This session is part of our educational series, Next Generation Prenatal Care, where we explore the future of maternal health. Healthcare today is full of challenges, balancing access with quality, integrating innovation, and ensuring that technology truly meets the needs of both clinicians and patients. We believe that by working together, sharing knowledge, and learning from both successes and difficulties, we can redefine prenatal care to be more adaptable and more patient-centered. The fact that you are here today, engaging in this conversation, shows your commitment to shaping the future of maternal care. Only as a community, by learning from one another, we will be able to drive meaningful progress and create a better, more connected healthcare. We are honored to host two distinguished experts here, Dr. Alex Peahl from the University of Michigan, who will be sharing the unique landscape of prenatal care in the US and how it is evolving. She will also discuss her Pulsenmore research outcomes. I'm sure all our global attendees will draw inspiration and valuable insights from her talk. Alex couldn't join us live today as she just gave birth a few days ago. She has kindly recorded her talk so we can benefit from her insights. Right after Alex, Dr. Tsur from Sheba Medical Center will share his experiences leading a first-of-its-kind hybrid clinic as well as an innovative home admission program. Those initiatives are helping to reshape pregnancy care, mainly for high-risk patients. Throughout the session, we encourage you to ask questions using the Q&A box. We will address as many as possible during the webinar, and any unanswered questions will be followed up through email afterwards. Thank you for being here, and let's get started.
Is Dr. Alex Peahl, and I'm a general OBGYN and health services researcher at the University of Michigan. I'm very excited to share with you our trial, BPP for Me, patient-operated remote ultrasonography for completing biophysical profiles for antenatal surveillance in high-risk pregnancies. You can see my disclosures here, perhaps most important of which is that I am a mom, and my experiences as a birthing person influence the way I come to this work. For today's agenda, we'll begin with a background of the work, including how tailored prenatal care delivery and antenatal testing fit into home ultrasonography. Next, we'll introduce the BPP for Me study, process, and results, and end with some conclusions. First, our background. We know that we are in the midst of a maternity care crisis in the United States. Birthing people are more likely to die in the pregnancy episode than their mothers, and outcomes are worse for the United States than any other peer nation. There is hope, however. 80% of maternal deaths in the United States are preventable, many through routine prenatal care. There is opportunity to do better. Said differently, we have 9 months to prevent adverse pregnancy outcomes. But are we? Current prenatal care delivery fails to detect and prevent adverse outcomes. In terms of access, over a quarter of patients do not receive care in the first trimester, with lower rates for patients who are Black, Hispanic, or have Medicaid. For service delivery, a recent study in commercial insurance claims showed that less than half of patients receive the most critical basic preventive services, including laboratory tests and immunizations within the recommended timeframes. And for experience, many patients, especially from groups marginalized by racism and living on low incomes, report negative care experiences, including not being heard or respected in their maternity care. In fact, 1 in 5 overall and 1 in 3 individuals from marginalized groups report mistreatment. These failures of routine prenatal care to promote access to evidence-based services and in turn prevent adverse outcomes are in part a failure of design. Prenatal care delivery in the United States has not changed since 1933 and includes 12 to 14 in-clinic visits requiring over 40 hours per pregnancy. And this is if everything goes right. Using this traditional prenatal care model is kind of like driving this 1930 Pontiac coupe down the street today. An interesting design, but not the right tool for the job. Prenatal care in the United States is changing for the first time in a century. In the height of the COVID-19 pandemic, ACOG, the American College of Obstetricians and Gynecologists, and the University of Michigan partnered to develop the first new prenatal care guidelines in a century. The resulting plan for appropriate tailored healthcare in pregnancy, or PATH, is represented here. When patients first present for prenatal care, they receive screening for medical and social drivers, and their preferences are asked. Together, these risk factors and preferences are used to determine a tailored prenatal care plan, individualized in terms of visit frequency and monitoring, the use of telemedicine and alternative care modalities, and support for social and structural drivers of health. Tailored pathways can promote access, choice, and improved outcomes for birthing people and their families. Here you can see representations of those different potential pathways. In this figure, dark blue circles represent in-person visits, and yellow circles represent virtual visits, with the paler blue representing the anatomy ultrasound. The targeted visit schedules are more appropriate for average risk patients, while the traditional visit schedule is more appropriate for patients with higher risk pregnancies. Unfortunately, telemedicine options have been limited for patients with high-risk pregnancies due to antenatal testing requirements. For patients with conditions like chronic hypertension and diabetes, or diabetes and hypertension of pregnancy, as well as fetal concerns like growth restriction, virtual care has been essentially inaccessible after the second trimester. These same conditions are disproportionately shouldered by populations marginalized by race, racism, and adverse social drivers of health, who often face the greatest barriers to care. Unlocking home antenatal testing is essential for improving care access, experience, and outcomes, particularly for historically marginalized groups who face the greatest barriers to care and highest rates of adverse events. Multiple options for antenatal testing exist, including the biophysical profile, an ultrasound assessment of fetal well-being that assesses 4 key parameters: amniotic fluid, gross fetal movement, tone, and breathing. And this test can be performed with or without a non-stress test. A non-stress test uses cardiotocography to assess fetal well-being and assesses 2 key parameters: fetal heart rate in relation to contractions. It is often performed with an amniotic fluid assessment. Biophysical profiles are on average much shorter than non-stress tests, requiring only 5.3 minutes compared to the 20 minutes of a non-stress test. Here you see representations of images from both forms of testing. There is insufficient data to support one form of testing over another. In theory, the fetal reaction to hypoxia or acidemia is similar in the central nervous system centers that control fetal movement linked to accelerations for the NST and fetal breathing in the biophysical profile. We would therefore expect that both tests would show similar responses to hypoxia or acidemia. A Cochrane review in 2008 concluded that there is not enough evidence to support the use of biophysical profile versus cardiotocography only for the assessment of fetal well-being in high-risk pregnancies. There is insufficient data to support one form of testing over another. In theory, the fetal reaction to hypoxia or acidemia is similar in the central nervous system centers that control fetal movement linked to accelerations for the NST and fetal breathing in the biophysical profile. We would therefore expect that both tests would show similar responses to hypoxia or acidemia. A Cochrane review in 2008 concluded that there is not enough evidence to support the use of biophysical profile versus cardiotocography only for the assessment of fetal well-being in high-risk pregnancies. So, is home ultrasound feasible? The Pulsenmore home ultrasound device is a patient self-scan device that includes an ultrasound transducer that integrates with a smartphone and an app that provides patient guidance. Patients are provided unique code access to limit scanning. This pairs with a clinician dashboard that allows for patient communication and image review. There are two modes of operation: clinician-guided, which includes synchronous communication with a clinician, and app-guided, which is asynchronous self-scanning by the patient with video guidance. Multiple assessments have demonstrated the feasibility of asynchronous and clinician-guided home sonography for confirming fetal well-being, including assessing fetal heart rate and amniotic fluid. One such study from 2020 is featured here, which included 100 participants and over 1,000 scans. Patients received in-person training using the Pulsenmore device and completed research scans asynchronously using the 6-sweep technique. On the right, you can see the results of the study, which showed high rates of detectability and inter-observer agreement on most parameters. However, a key gap between this study and the completion of home biophysical profile was the detection of fetal breathing and tone. So, could clinical guidance improve the detectability of biophysical components? Our objective was to assess the feasibility of patient-operated remote ultrasonography for completing biophysical profiles for antenatal surveillance in high-risk pregnancies. I will now review our methods. Our study design was an observational, non-intervention trial assessing the feasibility and acceptability of the patient-operated remote ultrasonography with clinician guidance. Eligible patients were pregnant and greater than 24 weeks gestation with a BMI of less than 40 and no fetal anomalies. Patients were presenting for planned antenatal surveillance, including biophysical profile for either maternal or fetal conditions. Patients were recruited through contact prior to their planned antenatal testing by a trained research assistant who completed the consent process. Consenting patients for training completed a video-guided training with the Pulsenmore device before their research scan. For the scan, patients logged into a video call with a trained sonographer who remotely guided the patient through an ultrasound using the Pulsenmore device with the modified 6-step approach. Patients then proceeded immediately to their clinical scan. And our primary outcome was the detectability of biophysical profile components. Here you can see a more detailed list of our eligibility criteria, including inclusion criteria and exclusion criteria. The Pulsenmore training included a 30-minute video provided by Pulsenmore. Training was completed in the clinical room with a research assistant present, but was completely guided by the patient and the app. Patients completed 10 multiple choice questions before proceeding to the research scan. During the research scan, the sonographer guides the patient through prescribed motions using the ultrasound device to collect information on key components. These include fetal heart rate, fetal positioning, placental location, amniotic fluid, fetal movement, and breathing. The sonographer uses a script modified from the 6-step approach to ensure that the movements are similar across research participants. Here you can see images representing the 6-step approach. Of note, though the sonographer worked from a script, they were able to pause the patient or ask for adjustment if key parameters of interest were seen during these prescribed motions. Outcomes of this study included the primary outcome of detectability of biophysical profile components. Secondary outcomes included agreement between the research and clinical scan for the biophysical profile components, including assessment of amniotic fluid, gross movement, tone, and breathing. Exploratory clinical outcomes also included detectability and agreement of additional components, including presentation, placental location, and fetal heartbeat. We also collected patient-reported outcomes. This included the use scale, usefulness, ease of use, and ease of learning and satisfaction to measure satisfaction overall with the device experience. We also included implementation science measures, including acceptability, feasibility, and appropriateness of the intervention to guide future implementation across broader settings. Other exploratory patient-reported outcomes measured prenatal care satisfaction, maternal attachment, and autonomy. And now for our results. 32 patients consented for the study. 2 were withdrawn due to logistical issues. Of the remaining 30 active participants, 25 completed both a Pulsenmore research study and a clinical scan. Here you can see the participant demographics at the time of the research scan. All demographics matched those of the institution where the study was completed. Average age was 32, BMI was 29. Patients had, on average, a gravidity of almost 3 and a parity of less than 1. You can see the participant breakdown by race on the right-hand side of the slide, with the majority of participants identifying as white. Here you can see additional information on the patient demographics, including insurance status, level of education, and social vulnerability index. The majority of patients were commercially insured. There was a mix of highest level of education and diversity in social vulnerability index, which is a representation of neighborhood level social vulnerability. Patients participating in the study had diverse medical history. The most common chronic conditions were anxiety and depression, with high representation of chronic hypertension and diabetes. Current pregnancy complications included gestational diabetes, intrauterine growth restriction, and hypertensive disorders of pregnancy. Here you see the overall results on detectability of key parameters on the research scan and agreement between the research and the clinical scan. On the left-hand side, you see the parameters of assessment, including those of the biophysical profile, in addition to presentation, placental location, and fetal heart rate monitoring. Of note, amniotic fluid was assessed 2 ways. One, by the assignment of 2 points by the clinician completing the scan, and secondly, by a deepest vertical pocket of greater than 2. The definitions of each of those parameters are located in this chart. As you can see, detectability of all components assessed was 100% in the research scan, and agreement was high for most parameters. Areas where there was not agreement included fetal breathing, where one research scan identified fetal breathing, though it was not identified on the clinical scan. The difference in agreement in the scans for deepest vertical pocket are the result of the clinical scan including an assessment of amniotic fluid overall, but not specifying the deepest vertical pocket. Placental agreement was lower between the 2 scan types, 56%. This was in part due to our process for collecting this data, and we've made modifications in the standardized script to help better collect this information. This may also represent some of the orientation challenges working with clinician-guided mode scanning. Patient-reported outcomes were high across categories, including the use scale, which measures user experience. You can see across all domains, patient rating was high, including usefulness, ease of learning, and satisfaction. Sample questions are included below each average score. Similarly, patient-reported outcomes for implementation were high, including those for feasibility, acceptability, and appropriateness, with all scoring almost 5 out of 5. This study does have some limitations. First, it was a feasibility and acceptability study with a limited sample size that will require proof in greater populations. All research and clinical biophysical profiles were normal. This means we can draw limited information on detection of abnormal scan results, which are overall rare. Finally, this study does have limited generalizability. It was conducted at a single site with a single sonographer leading the clinician guidance. This means we need additional data, not only across institutions, but also across clinicians providing the scanning guidance. In spite of these limitations, our study also has multiple strengths. We included a diverse population, including medical indications, education, and socioeconomic status, though racial diversity will be important to include in the future. Also, we include a combination of clinical and user data, providing information not only on the scan parameters, but also on how patients may experience home ultrasonography. Finally, the study provides important proof of concept data for future investigations. In conclusion, patient-operated remote ultrasonography with clinician guidance appears feasible and acceptable for antenatal surveillance in high-risk pregnancies. Still, future work is needed to confirm findings across populations and additional care settings. Thank you for your time and attention today. We look forward to your questions, and please feel free to reach out.
Hello, everybody, and a pleasure to meet. And thank you, Mira, and all Pulsenmore team for the opportunity to present some of our work. And my name is Avi, and I'll be sharing you our journey with maternal fetal telemedicine at Sheba. We started our journey back during COVID-19 pandemic, when our goal was to minimize the number of physical visits of high-risk pregnant patients to our antepartum high-risk clinics, while providing them best surveillance remotely. And even back then, a few years ago, maternal assessment remotely was already very easily achievable, and we could take it from other paradigms, from other clinical disciplines. However, fetal assessment remotely is a quite new thing, and for that purpose, we gathered our department leadership and decided that our strategy would be to combine the remote NST with remote assessment of ultrasound captured maximal vertical pocket, amniotic fluid maximal vertical pocket, to achieve the modified biophysical score. And just as a reminder, based on large data for many patients back from the 1990, the false negative rate of the modified biophysical score consisting of NST plus maximal amniotic fluid vertical pocket is very similar to the full biophysical score. And in this nice figure that Dr. Michal Exelrod created, it depicts our clinical paradigm: full maternal assessment, ongoing glycemic control, patient-physician encounter, digital urinalysis, vital signs, all the full maternal assessment remotely, together with, and that was our innovation, the online remote assessment of the fetus with NST and maximal vertical pocket. And these are technologies we work with. Heramed, that started the journey with us and published our first study for post-date pregnancy. Nuvo, that we're currently using for NST, that also provides assessment of uterine contractions. Healthy IO that we used in our GDM study that I will describe for digital urinalysis remotely. Pulsenmore that I'm holding today is a webinar, and you can see here the three-channel view. The patient sees us here. You can see me and Esti, our head midwife, the patient, and a dog sitting next to her on the sofa, and the star of the show, the fetus. And our technology at Sheba for communication with patients remotely, Datos, that provides the HIPAA-compliant video connection, ongoing assessment of glycemic control, and ongoing surveillance of blood pressure, all remotely. We assessed our work using clinical investigation. The first step was to assess feasibility, and you see here the study led by Dr. Omer Nir. This was a feasibility study, just testing the technology's work, that the patients are able to connect themselves remotely to the fetal monitor, was able to run the ultrasound themselves, since we know to assess it online, remotely. The study took place within the hospital. It was really a feasibility safety study. And I won't go into its outcomes because really it was a mainly feasibility and safety study. But I will mention one thing that we asked the patients also, one open question: what was their favorite aspect of the new service? And we received a very interesting answer that we will maybe discuss also later on. They were most excited beyond time saving, beyond the personal focus of the team in them. They were most excited of increased control and direct assessment of the fetus. So this was our first feasibility step, followed by the prospective study of women with gestational diabetes at home. Here you can see Dr. Michal Exelrod that led the study. So here we already, that's really the real thing. 20 participants, 40 with 20 participants. Each of them had 2 visits in clinic, the standard comprehensive assessment in clinic, versus 2 visits out of clinic. So it's 40 and 40 visits. One of the remote assessment, one of the patients withdrew consent for the study after 1 virtual visit. So we were left with 39 potential remote visits. Of them, we completed 38 or 39 successfully. One of the visits, one of 39 of a patient, BMI 40 at 32 weeks of gestation, we were not able to complete technically the NST remotely. The ultrasound was fine. All parts of the other parts of the assessment was fine. For the same patients, 2 weeks after, at 34 weeks of gestation, when the fetus grew a bit, we were able to complete the remote NST. For that reason, in these limits of BMI above 40 or gestation week below 32, before sending patients for remote care, we require twice NSTs that work within the clinic or the department before we try remote assessment. Otherwise, the study results were amazing. We had, of course, time saving was dramatic. 1 hour for the remote assessment versus 3 hours. Patients driving to the clinic, waiting for the secretary, waiting for the midwife, waiting for the ultrasound tech, waiting for the doctor, waiting and waiting. Dramatic time saving. We used the validated telemedicine usability questionnaire to assess usability and satisfaction with very good results. Thank God, no adverse events or safety incidents. And based on these findings, we of course wanted to move from innovation to transformation to really providing this service widely to all pregnant women that could benefit from it. When we talk about telemedicine transformation at Sheba, we think of Sheba Beyond, our virtual hospital led by Dr. Galia Barkai and Hadar Amir. And a real service needs a head midwife, and we recruited Esti, the amazing Esti Geller. That's our head midwife of the service. We have two agreements with 2 of our payers, Maccabi and another payer, providing full reimbursement for the comprehensive remote visits for all components of the remote visits, ultrasound, monitor, and of course, physician assessment. Beyond the technologies, Pulsenmore, that's holding today's webinar, and Nuvo for fetal monitoring, we keep assessing new technologies all the time. Now we are assessing Herabit technology for ongoing blood pressure surveillance in women with hypertensive disorders of pregnancy. Each patient has its own space at home. Here you can see one of our patients running the ultrasound. We are guiding her remotely, and you can see her in the balcony of a house on the seaside in Bat Yam. And of course, the next step of the service was extending it from the clinics to the antepartum high-risk admission. These women with very high-risk pregnancy that need to be admitted to the department, sometimes for many weeks until delivery. And in October 7th, following Hamas attack on Israel and one of the hospitals being harmed by a missile attack, we had to send some of the women home and be ready to send some of the women to the hospital shelter that has limited space. And we decided to leverage the same technologies we used for the remote assessment in the clinics, but you to use them intensely, a few times a day, for what we call intense remote care, replacing the standard high-risk pregnancy admission. And this is another case where crisis is also an opportunity for change. And going home, we learned a lot from our colleagues in the Netherlands that ran and published a seminal study published in the Lancet Digital Medicine, comparing 100 patients with similar indications to what we use: preeclampsia, fetal growth restriction, preterm rupture of membranes, reduced fetal movements, fetal anomalies, bad obstetric history. So they compared 100 women with a traditional standard high-risk pregnancy admission with 100 women followed remotely. They did not, in that study, they did not observe a significant difference between the group with standard care versus the remote care assessment. However, as you can see, there was one case of intrauterine fetal death at home. There was one case of eclampsia at home. And the question we asked ourselves before starting the service is whether we could potentially reduce the risk of these complications at home by adding some additional safety measures. And so we did. So we learned a lot from the Netherlands protocol, face-to-face training before patients go home, individual treatment plan, blood pressure self-measured at home 3 times a day, and the NST assessed real-time by midwives. And in addition, we added some safety measures. Instead of doing once a day NST, we do it between 2 to 3 times, depending on indication. We added, as I mentioned, the ultrasound, in the beginning modified biophysical. Now we are able to achieve for most patients full biophysical daily, together with the NST daily. In addition, the patients come to the hospital twice a week for Dopplers, as well as blood work. So we're able to, if patients, especially those with preeclampsia, develop HELP, we're able to capture it before blood pressure elevates. We also use the S-FLIT1 PLGF test to predict those that may develop severity features. We also run the urine protein to creatinine ratio twice weekly. So we have a lot of information of each of the patients at each time point. And the reason we call this hybrid care and not remote care is that really the patients come twice a week to the hospital. If there's a problem, we keep 1 bed for every 3 patients at home. And when they come to a designated area within the department. So from the point of view of the patients, there's continuity of care. It's the same team taking care of them at home and remotely. Here you can see Dr. Yoeli, which is director of the full antepartum high-risk department. And just as I assess patients in the department, she also assesses patients remotely. So from the point of view of the patients, there's full continuity of care, the same ST. They meet remotely and physically. And they also, of course, eventually give birth in our department. Here you can see Professor Shali Mazaki, our interim chair. And really there's a full support of the whole department, both those participating in remote care and those part of the standard care. All are very excited of this new paradigm. And as part of our safety measures, we have eligibility criteria. So it's only for patients that live up to 35 kilometers from our medical center or other centers that collaborate with us. It's only for women with pre-pregnancy BMIs lower than 40. Women that have BMI above 40 can join our service, but we have to run twice fetal NSTs that we see that work well technically. We do not send them home before we see that in women with BMI above 40. It's only for women after gestational age of viability. We do not know to assess remotely vaginal bleeding or women with contractions. We do not know to assess dilation remotely. We do not want non-compliant patients at home. Compliance is really important in this service. We depend on patients' compliance. We talk to them before they go home to assess compliance. We do not want a patient with a fetal deceleration at home that decides she doesn't want to return. We also have indication-specific contraindications. Women with preeclampsia that have severity features and are at high increased risk for eclampsia would not benefit from our service. Women that also have umbilical artery absence would not benefit from our service. In the case of intrahepatic cholestasis of pregnancy, women with bile acids above 100 that are at very high risk of intrauterine fetal death, also we do not allow hybrid care. So using these indications and contraindications and our clinical protocol, this is our data. We're currently concluding 1,200 days of intense remote care for indications as mentioned: fetal growth restrictions, oligohydramnions, hypertensive disorders of pregnancy, intrahepatic cholestasis of pregnancy, bad obstetric history, as well as women with pyelonephritis. We already had 93 women enjoy our service. We are very inclusive, ultra-Orthodox Jews, Muslims, and many of our patients, it's the first time they use a smartphone, and we find they learn very quickly. We had so far up to 7 women concurrently, and as we're expanding the service, we expect to see higher numbers now. The number of average admission days per patient is 12.9. We did not have so far, touch wood, adverse events at home. We did have one case of non-compliant patient that did not return after a technical problem with her fetal monitoring. Patients that are not compliant when they're required to return or with any aspect of the service, we request them to return to the regular service, because again, as mentioned, compliance at home is really important, not less important than the technology or the clinical service. We're all the time looking into adding additional technologies: continuous glucose monitoring, continuous blood pressure monitoring, continuous fetal monitoring. Clearly, the future is within technology. We developed a digital twin for ongoing assessment of the patients at home based on ongoing data collection. And of course, there are many additional aspects of the service to talk about, and I look forward for discussing them in detail later on in today's webinar. And this is my mail for any additional questions or opportunities to collaborate. I'll share with you one thing. Earlier this year, I traveled to give a few lectures about our new service in grand rounds of several departments in the United States. So I told my kids I'm going to give lectures about it, and they see me. In weekends, I assess our patients remotely on Saturday morning from home. So from their point of view, that's how admission looks like. Patients are at home. So they were really surprised. It's innovation. They thought that all patients are admitted at home. So I don't know if I persuaded you, but at least my kids are persuaded that this is the future of care at home. Thank you very much for your attention.
Dr. Tsur, thank you so much for your insightful talk. That we consider ourselves together with you a community, okay? A community of innovators and of clinicians that want to make a positive impact in prenatal care. So we're definitely interested in collaborating with you and connecting with you and between you, because just as a collective voice, we will be able together to drive meaningful progress and create a better, more connected healthcare. Thank you so much for being with us here, and have a rest of a very nice evening. Goodbye.